Hello, my name is Robin Mohr, and I'm a Senior Research Manager at the Institute for Health Metrics and Evaluation. For my WomenLift 2025 North America Leadership Journey project, I focus on health system adaptation during funding transition in Sub-Saharan Africa. As most of you are very well aware, we saw major health funding cuts and freezes in early 2025. Globally, Development Assistance for Health, or DAH, is estimated to decrease by 22% between 2024 and 2025, with a staggering 25% decline in Sub-Saharan Africa. In combination, rising debt service payments leave little fiscal space to fill the wide gap the funding cuts have left. This shows a more historical picture of DAH since 1990, with an obvious steep increase in response to the COVID-19 pandemic. What I want to highlight here is the majority of sources of DAH have declined from 2024 to 2025, with the United States representing the yellow bar at the bottom. There's also been a disproportionate effect on women and children. Reduction in HIV financing directly threatened adolescent girls and young women who account for the majority of new infections in sub-Saharan Africa. Additionally, cuts to global health funding directly correlate with reduced access to family planning and contraceptives and higher maternal mortality rates. My question is, what do these funding cuts look like on the ground in the hospitals, clinics, and communities who typically rely on donor funding? My approach was to utilize a recent IHME survey conducted by my colleagues, collecting data from over 50 health officials in 15 countries on African governments' response to the recent DAH cuts. From these survey respondents, I was able to conduct 7 in-depth interviews with health officials in Nigeria, Mozambique, Kenya, Ethiopia, and Cameroon. Through these interviews, I wanted to understand the real-time disruptions to service, drug supplies, and patient access. I wanted to uncover what adaptation strategies are being utilized at the community to fill the gaps, and also understand the burden placed on women and children. These are just a few excerpts from my conversations through my interviews, highlighting just a couple here. The malnutrition, the malnourished child in Ethiopia who is no longer receiving the therapeutic foods, who also have an inadequate vaccine response, or the clinician in Kenya who had patients flooding his clinic, worried about how they were going to continue the medication now that they were no longer free, in addition to managing an overworked and overstressed healthcare staff. As I said, I wanted to focus on the adaptation strategies that were happening. And a few examples are here. Engagement from retired health workers to mentor existing staff in Ethiopia who received small stipends and helped improve the quality of care patients were receiving. Or in Nigeria, in response to the therapeutic foods usually provided by donor fundings going away, and promotion of a local porridge called Tom Brown, also in combination with volunteers teaching mothers how to prepare nutritious meals using local ingredients. While these strategies are admirable and show great resilience among communities, they expose some deep inequities and rely on unpaid work. They're impressive, but they're unsustainable. This work changed how I think about leadership and not just how I look at health systems. I started this journey not knowing how it would end or really even begin. And I continued to go and lean into the unknown and the vulnerability I was feeling. I realized that true inclusion meant creating a space for voices that are often left unheard. I was lucky enough to utilize internal resources and tap into my wonderful collaborative colleagues at IHME to align my qualitative work with the broader institutional goals. I also hope that I also hope that I drove home the message that real people will suffer because of these cuts. I'm excited to say that through one of my interviews, I established a partnership with a collaborator in Nigeria where we hope to create and digitize a facility level questionnaire to capture funding impacts and local adaptation strategies, as I barely scratched the surface through my interviews. The goal is to expand beyond the antidotes and collect the data from multiple local governments, creating a publishable paper that keeps the global spotlight on the human cost of these cuts. Thank you so much for listening today. And thank you so much to the incredible Women Lift staff for their amazing support throughout this challenging year. Also, thank you to my IHME colleagues, Angela Apage and Joe Dielman, who initially conducted the survey, shared it with me, and helped walk me through some of the options I could take with my project. Also, Kelsey Pierce for her support throughout the past year. I also want to thank my WomenLift cohort friends. They've been the highlight of this journey in this challenging year, and I'm so happy to have gotten to know this wonderful group of women. Thank you again.